Afternoon, everybody. Thank you for coming. My name is Hernando Gomez. There's going to be another chair, Axel Nierhaus, who should be coming at some point. But in the sake of time, we will get going. We have a very exciting session today in renal replacement therapy, and the first speaker doesn't need any introduction. Professor Rinaldo Bellomo, please.
Thank you very much, Hernando. Okay, we're going to focus on practice variation within the START-AKI trial. Just to remind you, the START-AKI trial is the largest multicenter randomized controlled trial of management of patients with severe acute kidney injury, 168 centers, 3,019 patients, published in the New England a few years back. This is the flow diagram. Patients were randomized to two interventions. One was accelerated renal replacement therapy, and that was to occur within 12 hours of a patient fulfilling the necessary criteria, or delayed intervention, where you waited until more classical criteria for the initiation of renal replacement therapy. I'm sure you're all familiar with the final outcome of the trial, which showed that there was no difference in survival up to 90 days in the two treatment timing modalities or approaches. And this is the forest plot of the pre-specified subgroups within the trial, also showing no difference in the various groups of patients. One of the striking features in that trial, however, was in the secondary analysis, which showed that there was a statistically significant and a clinically important difference in renal replacement therapy dependence at 90 days, such that if you waited and you perform delayed or a traditional or a standard approach to initiation of renal replacement therapy, you had a significant decrease in the risk of becoming renal replacement therapy dependent at 90 days, which is what defines end-stage kidney failure. So this is all good, but then this is superficial, right? This is telling you the global movement of all the patients in the trial, and you really want to try and understand why that happened and whether it applies to patients that have been treated with different modalities. And this is the first sort of post-hoc analysis of the trial, where we focused on what happened to patients according to whether they received continuous renal replacement therapy as the initial modality, or whether they received intermittent hemodialysis as the initial modality of treatment. It doesn't take a statistical genius to note that all of the stuff is on this side of the midline in favor of continuous renal replacement therapy. We're looking at the combined outcome of mortality and renal replacement therapy independence at 90 days. So when you looked at this outcome, you found that the difference between the two was significant, with a 19% relative risk decrease, the combined outcome of mortality and renal replacement therapy dependency. However, you find that most of it, if not all of it, is actually driven by the renal replacement therapy dependence. So that's interesting, and that suggests that maybe if we start people on CRT, we would be able to decrease the risk that these patients will go on to be dependent on dialysis at 90 days. However, there is another reality underneath that, and that is that the use of continuous renal replacement therapy and the use of intermittent hemodialysis appear to differ according to the regions where patients were treated. And this is what we've gone on to look at. This was just published last month, which is a further post-hoc analysis of the START-AKI trial, trying to focus on the differences between different regions where the trial was conducted. So we divided the patients in the START-AKI trial into the three major regions where the trial was conducted. There were some patients who were randomized in China and in Brazil, but the number of patients overall in those two regions was very small and made it impossible to really have statistical power to determine whether there were any differences. And the first thing that you notice is that different regions treat different patients. And so just to look at an example, in the trial, if you were in Europe, about 74% of the patients in the ICUs that participated in the trial were medical patients. In Australia, it was only 48%. In Australia, a lot of the patients had scheduled surgery, which was twice as common as in the other two regions. Similarly, unscheduled surgery was a lot more common in the Australian ICUs that participated. And if you look at the types of admission diagnosis, you can see there that cardiovascular diagnoses were much more common in Australia, and you might, for example, find that neurologic diagnoses were more common in Europe, and so on. So the regions, or rather the centers that participate in START AKI in the different regions, appear to be treating different patients. So that's the first observation. The second observation is then they treat these patients differently. And so if you're admitted to one of the ICUs that participated in North America, CRT was used 60% of the time. Europe, 56% of the time. Australia, 95.7% of the time. So very different style of practice. I'm not saying one is better than the other. I'm just saying this is a very different style of practice. There are also differences in comorbidities. And so you can see there that there are differences in hypertension. The North Americans have a lot of diabetes, a lot more than Australia and Europe. There are differences in liver disease as well, with the North Americans having a higher incidence. You can see that a lot of the patients had been having cardiovascular surgery and cardiopulmonary bypass in Australia and New Zealand, very much more than in the other centers in North America. So really quite different. And it's also different the way people might have been exposed to these risk factors. And you can see that there, in Europe, 20% of thereabout got aminoglycosides before the patients were randomized. This is like 6 times more than in the North American center. So there are really profound differences. Okay, there are also differences in organ dysfunction and physiology. You can see that the SOFA score, the components of the SOFA score, the physiology, respiratory rate, the use of PEEP, the cumulative fluid balance before randomization, the pH, the creatinine, and so on, all quite different again. And then if you look at the use of vasopressors, 64% in North America, 63% in Europe, 73% in Australia and New Zealand. So again, styles of practice, 41% use of diuretics before randomization in Australia and New Zealand, only 25% in Europe. We practice differently. The population of patients is different. It's really quite striking. Now let's stop for a moment with fluid balance. This is the fluid balance after randomization at the top, and the fluid balance including the pre-randomization fluid administered. So after the centers were randomized in North America, the fluid balance at the 14 days follow-up was positive 2 liters, Europe 2.9 liters, in Australia was negative 400 mils. And if you take into account the fluid that was given before randomization following admission, you can see that in North America, the overall tally at 14 days is positive 7 liters, 5.6 in Europe and 2.2 in Australia. This is a graphic representation of this difference. You can see fluid resuscitation is dominant in North America prior to randomization, similar in Europe and in Australia and New Zealand, and then it goes down, and you can see that after randomization there are clear differences, as I previously presented to you, in the way patients are managed in terms of fluid therapy. What about the outcomes of these patients? This is a crude representation of outcomes in the 3 regions. And you can see 90-day mortality in North America was 45.9%, 41% in the European centers, and in Australia and New Zealand centers, 31.8%. And these differences continue for ICU mortality, renal replacement therapy dependency, which goes from 10% in North America to 3.2% in Australia and New Zealand. But as you've seen, we are dealing with different patients. So you try and do adjustment using multivariable models, and this is an adjustment for age, sex, SAP score, type of admission, presence of sepsis with the sites as a random effect. And you can see that these differences remain when you're comparing Australia, New Zealand to North America, Australia, New Zealand versus Europe, but you cannot see any differences when you're comparing North America versus Europe, suggesting that Australia and New Zealand is the deviant kind of environment in terms of these outcomes. But then you might say we should adjust harder, we should adjust more. So we added adjustments for medical admission diagnosis, hypertension, diabetes, heart failure, liver disease, use of cardiopulmonary bypass, aortic surgery, IV contrast, aminoglycosides, sepsis, pre-morbid GFR, SOFA score, frailty score, pre-randomization, respiratory rate, cumulative fluid balance, and so on and so on and so on and so forth, to see whether we would be able to eliminate these differences that appear to exist between the different regions. And again, we could not. There were still persistent differences which were not present when comparing North America versus Europe, but were present when comparing Australia and New Zealand versus Europe and Australia and New Zealand versus North America. There were differences within the European countries. So France was the biggest recruiter for the European component of the START-AKI trial, and it appeared that the patients admitted to French ICUs within START-AKI had a different management of fluid. You can see a more positive fluid balance after randomization, and including the pre-randomization fluid, again, a more fluid positive approach compared to the other European centers. Compared to the other European centers, however, France appears to have sicker patients, and you can also see here that after you adjust for all of the differences that we were able to identify, there is still a difference in favor of the non-French European centers in terms of mortality. Did the type of intervention and type of timing of intervention that you were randomized to, like the accelerated intervention group, show any difference? And the answer is, of course, you lose statistical power because now you have halved the number of patients you're looking at, but the differences, the relative difference of about 10% persists in this population. Standard care, again, the same difference persists in this population, even though you've lost statistical power and you cannot determine that this is statistically significant in the same way. And this is the graphic representation of time to mortality according to the overall cohort, accelerated arm and standard arm, and according to the regions within START-AKI, Europe, North America, and again, Australia and New Zealand is the deviant group of patients. Finally, this is a representation of renal replacement therapy-free days, which again is significantly greater in the Australian and New Zealand centers. So this raises some interesting questions. The first question is, why do ICU doctors in Australia and New Zealand give less fluid? Well, the obvious answer is they're seeing different patients. They like vasopressors. But that begs the question, why do Australian and New Zealand doctors like vasopressors more than people elsewhere? We don't know. Maybe we got greater availability of vasopressin. Some regions of Europe do not have that ability. Maybe we responded more to data. The fluid accumulation is associated with unfavorable outcomes. But then, the journals are available to everyone, so it's not really clear why the Australian and New Zealand doctors would respond to that more than other doctors elsewhere. It is possible that one of the reasons is that we work in a closed ICU system. So no doctor can come into the ICUs of Australian and New Zealand centers and prescribe anything, because all prescription of fluids or medications must be and can only be done by intensive care doctors. That means that there is a more focused, more intensive care-driven approach, and that might be one of the reasons that we have this difference. Maybe our patients are not as sick as those treated in European centers or North America. But then, of course, it begs another question. Why aren't they? Why aren't they? Okay, Australians are ex-convicts that were transported by ship in shackles, malnourished, and they still survived a 3-month journey, and so they are made of a harder stock. Possibility. It's possible that we have better resources, but I think it's difficult to argue that we have better resources than Canada or other centers in the United States. I think this is important. We have one-to-one nursing, and that's way different from France, from the rest of Europe. One-to-one nursing. We will not let that get touched by administration, by the government, by the Russians, by anyone. This is really important. It's developed at that historically, and we will defend it to the death. All our nurses are trained, and they're all highly trained in intensive care, and I think that's really an important component. And of course, there is the issue of renal replacement therapy use as the first modality. So let me conclude by saying that START-AKI showed that exposure to RT increases the risk of chronic renal replacement therapy, making a powerful argument for being conservative. And that's fine. But when you go back and you look at it a little bit more in detail, it's a complex situation because patients are treated differently in different regions. Fluid balance is modified by regions more than anywhere else. And the region thing is more important than the randomization, than the intervention, and just about anything else. CRT use is regional, and it was regional in that study. And for some reason, Australian and New Zealand patients appear to have a better outcome, which is unclear and probably is multifaceted and very complex, but nonetheless provides a provocative path to try to understand what might be best care for these patients. Thank you.
Thank you, Professor Bellomo. We have maybe time for one question from the audience. If nobody, I'll take the prerogative of the chair and ask you. So you focused sort of the explanation a little bit on fluids, which is an interesting topic. But I wonder what you think about the fact that the differences between using IHD versus CRT were so massive, and particularly because you've shown also that those patients did worse. So can that explain the differences that we see?
Ultimately it's an observational study, right? And, you've got all these variables. You can try and adjust. We adjusted for about 23 of them. But, it really doesn't resolve the problem. There's so many other variables that we're not really measuring that's underneath that. You know how I feel. I've been carrying on about continuous renal replacement therapy for 30 years, telling people just use CRT. The major reason for using IHD is you want to let the patient go home to play cards in the evening. They're intubated, ventilated, they can't get out of the ICU, just do CRT. However, there are financial constraints, there are logistic constraints, there are social constraints in different regions of the world that make it impossible. And, why Australia has made it possible, why Australia and New Zealand have made it possible or not, is very historical. Like, it's just the way it's developed, and that's the way it's been, and now it's untouchable. But I fully understand that it's not so simple as saying, well, just do it. It's not as simple as that.
I agree. Well, thank you very much. In the sake of time, we'll continue on.
Thank you. Now it's my pleasure to introduce the next speaker, Dr. Villa from Firenze, Italia, who will talk about the basic questions to raise.
Good afternoon. Thank you. So in my presentation, I will try to recover some minutes. I will try to explain the basic questions that everyone in real life should raise in the field of renal replacement therapy. So when we are at the bedside, one of the first questions that we should raise is, this patient is sick, this patient has some needs, but these patients need renal replacement therapy. The indication of renal replacement therapy is something that has been deeply discussed in the literature. So we now agree about the absolute indication of renal replacement therapy in those conditions, in patients who presented this absolute indication. We can say that we agree all that these patients need renal replacement therapy. Some kind of uncertainty still exists about the relative indications for renal replacement therapy. Also because the concept of relative indications relies on somewhere among the capability of the patient's kidney to maintain stability in terms of renal functional reserve during the disease, the capability of the physician to counteract the pathophysiology of the underlying disease, so for example, source control, antibiotics, remove nephrotoxins, and basically the trajectory of the disease. It is a concept that is very difficult to be defined, is very difficult to be objectively explained at the bedside, and nowadays the physician perception of adequacy of renal replacement therapy still remains one of the first driver in this particular condition for relative indications for renal replacement therapy. Nowadays, in clinical practice, the relative indications for renal replacement therapy are something that can be usually objectivied with a dynamic test, as for example, furosemide stress test or echographic stress test for renal resistive index variation, for example. But however, if the patient have absolute indication or relative indications for renal replacement therapy, please take a moment to think about the futility of these treatments, the respectful for the patient's autonomy, shared decision making with the patients, with the family in a multidisciplinary approach should be the basis of our approach for these important with high cost treatments. If uncertainties exist, a time-limited trial can solve this kind of ambiguity at the bedside. So we have decided that these patients need a renal replacement therapy, but does he need renal replacement therapy now? The timing, the concept of timing is probably the highly debated in this field. And it is strange because in the last decade we have up to 5 randomized clinical trials on this topic, and 4 of them have demonstrated that an early approach may have some negative outcome of our patients, in patients without an absolute urgent indications for renal replacement therapy. So some concerns exist now on the proactive approach of renal replacement therapy, that is a treatment as every kind of blood purification therapies, potentially with some adverse effect. And a watch and wait strategy seems to be more safe up to a certain point that in clinical practice still should be identified practically. But I don't want to spend time speaking about timing, also because the next speaker may be probably more focused than me. So we have to treat these patients, we have to treat this patient with a specific timing, but which target I'm establishing for this kind of treatments. The difference between indications and targets is something that should be discussed in this field. Now we know that renal replacement therapy can do a lot of things, not only remove uremic solutes, fluid balance, or restore, for example, electrolyte or ACE-based disorder, but several targets can be nowadays recognized at clinical practice. At the bedside, we want to reach all these targets, and to reach this target, we need a strategy. It is interesting. These are data from real practice coming from more than 1,000 patients. In extracorporeal blood purification therapies are nowadays adopted widely in the ICU. Up to almost 10% of patients are treated with a form of extracorporeal blood purification therapies, and in 2/3 of these cases, they are septic patients. Obviously, we can treat patients with a sort of absolute renal indications, or a combination of renal and not renal indication as, for example, immunomodulation. And this makes sense in specific conditions as, for example, sepsis. But also in non-septic patients, we can find rationale to put together renal replacement therapy and a sort of immunomodulation. Indications are quite interesting to be understood. But what is really interesting is that, for example, for patients undergoing renal replacement therapy for a renal indication, the physician asks some other targets that wants to be reached at the bedside. Why? Because if I have to start with a renal replacement therapy, I can take advantages from other disposable that may allow to do something else, as for example, interacting with the pathophysiology of the disease. Or in those patients in which renal replacement therapy had not an indication, absolute relative indications, in that specific patients, why are you adopting hemodialysis filter or disposable that allow you to remove substances in water? Because if I have to immunomodulate the patients, I can facilitate my treatments adopting an hemodialysis filters which allow me to have a more simple fluid control or eliminates uremic substances. This is an interesting approach, the combination between what is a renal replacement therapy and what is something more as, for example, extracorporeal blood purification therapies, and the capability to adopt disposable primarily made for extracorporeal blood purification therapy to make renal replacement therapy feasible is something that we know very well because, for example, during COVID, we took advantages from this strategy. Do you remember how difficult was to treat patients with COVID, patients with an hypercoagulable state in which the adoption of hemodialysis filters with heparin coating might help us in reducing, for example, membrane fouling? Or, for example, hemodialysis filters with augmented absorption capability that combine extracorporeal transmembrane clearance with some form of absorption to increase the capability to depurate these patients, not from cytokines or endotoxin, but to maintain renal replacement therapy feasible in these patients. And the same, for example, with high cutoff membrane. Most of these patients were treated with high cutoff membrane not for the removal of cytokines, not for immunomodulation, but to make renal replacement therapy feasible in a patient in prone position, with a potential vascular access malfunction, in which the blood flow was not so high and filtration fraction was very high. So diffusive clearance with a high cutoff membrane in the concept of the expanded dialysis. The potential to combine different disposable to reach a specific target is probably the most important question that should be raised at the bedside. So, we want to treat these patients. We want to treat these patients with a specific time point. We decide target, and now we need a strategy. We need a prescription. We need the perfect prescription, which is not only the dose. It is not only a milliliters per kilogram per hour set in the machine, but it's something more complex. Something that considers together different variables, different resources to make a strategies. Which kind of therapy? Continuous therapy, hybrid therapy, intermittent therapy? Which monitor we want to use at the bedside? Because different machine has different capability to solve our problem. what amount of convective dose, diffusive dose, the number of milliliters per kilogram per hour, how should be reached in terms of percentage of convection and diffusion to remove the substances which are decided as a target of the treatments. Which anticoagulation, which solution should be applied? The most important thing is to remember that prescription is not a point in the field of renal replacement therapy, but instead is a dynamic process that starts with the initial prescription and continuously evolve in a sort of holistic strategies that put all these research together to achieve those well-defined targets, but they have an effect only if we are able to maintain under control what we are doing. So, after the initial prescription, what I am actually delivering to these patients? The capability to measure what you are doing is probably the most important thing of renal replacement therapy. We know that what we prescribe is never what we are delivering. We know that downtime may reduce the effective delivered dose. This is usually expected. The downtime can be quantifiable, treatable, preventable, and the technological evolution in several machines with auto-effluent downtime compensation may reduce the effect of downtime in our treatment. But downtime is not a problem. The real problem is membrane falling, which is expected always in every kind of treatment, extracorporeal blood purification therapies, but it is unquantifiable. It is untreatable. We cannot prevent it, but we should try to apply pharmacological, not pharmacological strategies to reduce clotting, clogging, but please, at least once a day, measure the current effective delivered dose. So measure the biological dose that you are delivering to your patients. Otherwise, no study can demonstrate something in our patients treated with renal replacement therapy. And multiple stakeholders have a responsibility in this field. The same manufacturers should help us in providing tools to maintain under control beyond the effluent dose what we are delivering to the patients. We should maintain this kind of capability to measure the clearance at the bedside. Also because without the knowledge of what we are delivering, not prescribing, because we know that these are different, we cannot understand if our strategies, policy are really effective in our ICU. So we should monitor our practice, and in these terms, registry, for example, has an instrument to have an objective picture of what you are delivering and obtaining in terms of outcome is quintessential. Registry as an observational study that can not only produce data to increase knowledge or suggest a cluster of patients in which a future randomized clinical trial may evaluate effectiveness in specific strategies, but to obtain quality indicators, quality improvement, continuous quality improvement of your policy, your strategies in the field of renal replacement therapy, integrating clinical and technological data. So, although the renal replacement therapy has been a major topic for critical care medicine in at least 4 decades, many questions remain in clinical practice. Some of them probably are now well understood. So, for example, continuous treatment for hemodynamically stable patients, or which kind of anticoagulation we should apply in renal replacement therapy in continuous treatment. Some others have a moderate level of precision. Just think about the dose prescribed, the amount of dose prescribed in milliliters per kilogram per hour. Other, we are quite blind. Just think about the concept of timing, the concept of indication. Some suggest exist, but we are still talking about that. Our ability to monitor and control what we do, both in terms of what we deliver and at patients' bedside and policy and strategies, is probably the most important determinant that can promote precision medicine at the patient's level and continuous quality improvement in our centers. Thank you.
Thank you very much, Dr. Villa, for putting our feet on the ground again. That was an important talk, I think. Any questions and comments from the audience? Please use the microphone. If not, can you give me some idea of quality indicators for a successful and high-quality renal replacement therapy at your unit? What indicators are you using or are you recommending?
The first thing is that every ICU has different endpoint for quality indicators, and it is a little bit strange that different ICU may share the same different endpoint for quality indicators, because, for example, I work in an oncological ICU, and for me ICU mortality is not at all important at the bedside. Neither 30-day mortalities, for example, working with hematological malignancies, probably can be of some importance. The quality of life, autonomy, the amount of multi-drug resistance, super infection that we have in patients treated with extracorporeal blood purification therapies, or the capability to maintain a good relationship between physician and patients despite the critical illness in our ICU at the bedside. The first thing that we should do is decide in our environment with our patients what clinically important is, and only after this step measure everything and try to obtain objective conclusion as much as possible, observing your patients, your important outcome, your policy, your practice in your environment with your patients, and so on.
You made your point. Thank you very much.
Thank you.
Very well. So we'll carry on with Professor Patrick Honoré.
Okay, thank you so much for the kind introduction. So in the next 15 minutes, I will try to focus on new ideas regarding citrate. And I will focus mostly on liver failure, also the metabolic complication, especially the citrate accumulation, and is there a relationship between the severity of liver failure and the citrate tolerance? That's a big question. Okay. So, overview. Classical metabolism, all known by you, mitochondria. Then metabolic complication, as I said, and I will mostly focus on citrate accumulation. Then there are obvious contraindications. I think yes. There are also relative contraindications. Okay. And again, liver failure and citrate. Is it predictable? Not sure. Liver failure and citrate, feasible? Of completely crazy? Might be. And an hypothesis, is there an inducible alternative pathway outside the mitochondria in the liver and the muscles? Not sure. And some conclusion and perspective. And you all know this very well, better than me, that obviously citrate is mainly metabolized in the mitochondria. And as you know better than I, it's obviously the liver in 65%, the kidney is almost cracked down. And so you have also the muscle. If you have a guy who is playing basket of 2.20 meters, maybe more muscle, but you know. So what is important is obviously that this mitochondria is only running when she gets oxygen. Without oxygen, everything falls in place, out of the place. And then obviously that's going to be a very embarrassing, especially if you are cutting down oxygenation, as I will show you. So, obvious contraindication. Okay. Liver cirrhosis, child puke, C. Makes sense. Poor muscle perfusion and oxygenation after cardiac arrest. 30% of the muscle are doing the work. Not bad. Refractory heart failure with reduced peripheral perfusion, severe ischemic hepatitis, or fulminant hepatic failure, that's even more worse. So, common sense would say, well, if you are in a small ICU, if you're starting just doing citrate, keep this as contraindication. Obviously, if you are working in this field since maybe 10, 15, 20 years, you may perhaps try to see if you can perform this, although the liver is in poor condition. But you have to be very cautious. And again, I emphasize that if you are really starting in a small place, do not start. And if we start, we have to rely on what? Ooh, good question. Liver test, useless. What we do? Well, this lady, Karin Schultweis from Germany, said the only test that I rely on to start without having citrate accumulation is lactate above 3.4 millimole per liter and PDT less than 26%. Okay. But be cautious. Everything should be titrated. Monitoring should be very tight. And pray, perhaps. Right. If failure, stop, obviously. Now, relative contraindication. Somewhat different. So, severe shock plus lactic acidosis. Okay. Severe septic shock plus lactic acidosis. Metformin intoxication with circulatory involvement. Shock, obviously. Any shock status with a high lactate should increase at least awareness, even more, obviously. And then we know that small children, less than 10 kilo, have an increased risk of toxicity and accumulation, including more sensitive heart to hypocalcemia, to ionized low hypocalcemia. Well, indeed, in this group, you may try, and in the majority of the case, it will go well, especially in this metformin intoxication, but not every time. There is a minority of patients who will develop, whatever you do, citrate accumulation. Now, what is citrate accumulation? You know that in the classical way, you have bound calcium in the blood, plus the ionized calcium, which is so important for the heart. And then, if you have a citrate accumulation, you have a third player in place. You have calcium citrate increasing all the time in the blood. So the calcium, the total calcium is being so big. And the ionized calcium is shrinking. And so, And so, obviously, you have a risk of cardiotoxicity. That's embarrassing, no? So, if we look to the steward approach, and we have the principle of electron neutrality, and you look on this slide here, you see that citrate is increasing in the blood because you have citrate accumulation by definition. So that's make shrinking bicarbonate and chloride. So by definition is increasing the anion gap and also having acidosis. Just simple description. Hypernatremia, you don't have these today. Hypocalcemia for ionic calcium, and hypercalcemia for total calcium. You could have also hypomagnesemia, hypokaliemia. And obviously, you will have a high total calcium, and the calcium ratio, total over ionized, if it's above 2.5, be careful, because then you may induce citrate accumulation and the patient can be dead quite quickly. So metabolic acidosis, as I said, high anion gap, increased lactate, and if you have the chance to have citrate level, which is very difficult, when it's above almost 30 milligram per deciliter. Okay. Now, if you are, let's say, a bit embarrassed and you want to try, but the calcium ratio is slightly below 2.5, then you may not only use the calcium ratio, but also the demand for calcium substitutions, which gonna increase a lot. And also, the lactate, especially, might be not normal at the beginning, but if it's rising, then you have to be very, very cautious. So use 3. Calcium ratio, increase in demand of calcium substitution, and increase of, especially the evolution of lactate. If it's rising, stop everything, please. Now, as I said, Caroline Schulte said, okay, liver test, use this. Go in the bin. So just proton time less than 26% and serum lactate above 3.4 millimole per liter are risk factor in my ICU for citrate accumulation. Nevertheless, she did it, and she said it was feasible. So again, what is the relationship with liver involvement severity and citrate tolerance? Looks like we are missing something, at least me. Maybe not the other. So, Klingele from Germany, again, was seeking 69 severe liver dysfunction patients. And when he started the study, he said, well, I'm expecting 70 patients with accumulation of citrate, maybe less than 5% no complication, and less than 5% metabolic alkalosis. And when they get the result, ooh, impressive, 53% no complication, 23% accumulation of citrate only, coming from 70, well, it was obviously expected, and 24% of alkalosis. So totally reversed. So in other words, you may have a child puke C, and he will tolerate citrate, and you may have a child puke A, and he will not tolerate citrate. How can we try to get forward in this condition? So they conclude, the first one to say this, that this indicates an extra hepatic metabolism of citrate outside the mitochondria. What is this? Hypothesis, obviously. Avoiding, in most cases, citrate accumulation in critically ill patients impair liver function because the citric acid cycle is oxygen dependent, as I showed you in the beginning. And they had, from their experimentation, a disturbed microcirculation that will result in inadequate citrate metabolism. And, very important point, when you raise the calcium ratio for them, it's an indicator of severity and mortality, not of liver failure. So we are changing completely the games here. Okay. Right. Now, further, Klingele, the first to say this, because in all cells, citrate can be metabolized within the Cori cycle, we hypothesize, obviously, that an impaired perfusion on the microvascular and cellular level is critical to the metabolism of citrate. This hypothesis is supported by the initial observation of Schultheis as I showed you. And also link, we showed that when the lactate clearance was decreased, there was a major risk of citrate accumulation. Making sense, obviously. And we had, a few years ago, 2 neonates, when we have to be very, very, very cautious when we do CRT with special devices. And there were 2 neonates with mitochondrial cytopathy. And we obviously said, well, we will start CRT because they were in severe AKI, and we will try conventional heparin. And then, no luck. We had bleeding complication in the 2 patients. My God, what shall I do? Okay, we try citrate and we try no coagulation, but we had half-lives of 8 hours, even less. So we spoke also about heparin and protamine, but this is not easy to do in a neonate. So we said, after consulting all the people, should we try a very small dose of citrate? And then, indeed, we tried. And surprisingly, we've done a very tight monitoring, and after 96 hours, the 2 neonates were able to metabolize citrate despite citric acid cycle dysfunction. Not completely out, inferring an activation of an inducible pathway, alternative pathway. But again, this is an hypothesis. Okay, so the liver citrate anticoagulation threshold, LCAT, from Thorsten Slowinski from Berlin, showed again that in severely impaired liver failure patients, out of 90 patients, only 3 patients were out of the game for citrate. So again, he was saying, there's something here that I do not understand. I'm not the least. Okay, so there are some ways to minimize the risk of citrate accumulation. You have to have a strict protocol. Then you should have care about decreased citrate metabolization, like acute liver failure, circulatory shock, intoxication. Again, you have to be cautious if you start, and these are contraindications. You have to have a close monitoring of ionized calcium post-filter for efficacy and systemic for safety. And then you can add the infusion increase of calcium and the lactate kinetics. And if you have good protocol, normally it would work. And how? Well, you limit the blood flow, and there is a relationship with citrate. Then you limit the citrate. And maybe you can reduce the calcium ratio. Another way is to use a high dialysate filtration rate to favor citrate removal. Now, my conclusion. Classical metabolism of citrate is obviously in the mitochondria, mostly in the liver and in the muscle. Okay. There is the issue of citrate accumulation. We have absolute contraindication, relative contraindication. Okay, fair enough. We know from Schulte's liver test in the bin. We can only use lactate above 3.4 and PTT less than 26%. Not that much. And in severe liver failure, citrate accumulation was only seen in 20% instead of 70% when they were, sorry, there was a mistake, 50, when they were assuming this. And so, in other words, there is no relationship between the severity of liver failure and the citrate tolerance. So far, we don't know. We are in the dark. That's bad. To monitor citrate in liver failure, calcium gap, infusion of calcium, lactate kinetic. alternative inducible pathway to the cortical might be the alternative that is increasing, especially when you have chronic liver disease, but still an hypothesis. Neonate with liver cytopathy can tolerate, in some cases, citrate. Citrate is less dependent to the liver in hepatic failure, but more on microcirculation. And more important than everything else, it's only an hypothesis, and we need loads of new data on this. Thank you so much for your kind attention.
Thank you so much for this very, very interesting and entertaining talk. Any questions from the floor? Don't be shy. Anybody? No? Okay. I have one question. So it's clear from the data that you presented that lactate seems to be one of the red flags to be used. But I wonder, what does that mean in terms of what is it that is happening in the patient that cannot tolerate citrate? Because we know from the septic literature particularly that lactate is not necessarily a representation of hypoxia or ischemia. So what do you think lactate is representing here, and how do we advance from there?
Mm-hmm. It's a very good point. I think there are two possibilities, plus the possibility you mentioned. The second possibility is obviously liver insufficiency. But when citrate is tolerated, it's not really the case. Then some authors has put forward a nice hypothesis, which is microcirculation failure, saying that not only the liver cells are not able to do the job for citrate, but the other cells, the alternative pathway, are blocked also because of the microcirculation failure, and this is rising the lactate. So lactate cannot differentiate between the two of the three, but it's present for different reasons. And when citrate is tolerated, and you think it might be an alternative pathway, although we need to prove this, then think about the microcirculation. Obviously, improving the microcirculation, that's another issue. But that's my answer.
Excellent. I think we have a question from the audience. Go ahead.
Yes, hello, Patrick. Joop Jonker, University Hospital of Brussels. I find that idea of the alternative pathway very interesting. However, I'm wondering if it is a metabolic pathway that changes, because all of our cells can metabolize citrate because it's part of metabolism, of course. The reason that the liver cells metabolize citrate is mostly because they have transporters outside of the cell to get them inside. So maybe that's something that can change in all of the cells. Could you comment on that?
Yes, that's a very good point. In fact, we've been speaking a lot with biochemists, doing some thinking about doing some new studies, experimental studies, and the mouse is the best animal to do this because it's very similar to the human, and also we can easily induce cytopathic issue in these mice. And in fact, this is totally true, Joop, that you could have maybe a pathway of maybe a transporter. You're fully right. I cannot make the difference at this time. But we will go to do mice experimentation to see when we reproduce the high lactate and the cytopathy, if what is on the stake, is this the co-recycle or a transporter? We don't know yet. Fully agree.
Thank you very much. For the sake of time, I think we have to go on, and it's my pleasure to announce Professor Stéphane. Thank you. It's my pleasure to announce Professor Stéphane Gaudry from Paris, France, who will talk about hybrid therapy for which patient.
Thank you very much. Very happy to be with you this afternoon. So I will talk about hybrid therapy and for which patients. here are my disclosures. I received grants from French Ministry of Health and French Ministry of Research, and one of these grants is a trial, is to fund a trial comparison between intermittent and continue. Okay, so hybrid therapies encompass many names in the literature. You will see extended daily dialysis, SLED, PIRT for prolonged intermittent RRT, but the principle is always the same in the literature. But I would like to start with a provocative statement. Hybrid therapies do not exist. Why? Because I think that hybrid therapies is a kind of intermittent RRT done properly for ICU patients. And you will see that I disagree with Rinaldo Bellomo on this question. So you have three kind of modality for extracorporeal renal replacement therapy: intermittent, continue, and possibly hybrid therapies. But you can see that the first paper on dialysis for acute renal failure by the inventor of hemodialysis, William Kolff. In this paper, Kolff performed hybrid therapy. The duration was 11 hours. The blood flow was 116 milliliters per minute. So it was hybrid therapies. So what is the problem with intermittent and continue RRT? The problem is it is always the hemodynamic instability related to RRT. And many authors think that hybrid therapies may provide more hemodynamic stability for our patients in the ICU. By reducing the efficiency of solute clearance, by extending the duration of the session, you may promote hemodynamic stability in your patients, in your ICU. Okay, but we have to compare continue and intermittent to understand this question. And I think that intermittent hemodialysis is associated with many advantages. It is widely available. It is better for transportation. And in my ICU, I'm sorry with Rinaldo, but I need to go to the CT scan with the patient, and I start rehabilitation in my ICU. It allows also rapid correction for metabolic abnormality, and you have no anticoagulation option. Okay, but probably we have one disadvantage. It's the hemodynamic instability. But we know now how to improve hemodynamic tolerance of intermittent renal replacement therapy. These strategies are very well described in the literature. Isovolemic initiation, reduce dialysate temperatures, reduce the dialysate flow rate, you use bicarbonate buffer, and of course, a very important thing, use a conservative ultrafiltration. So it's possible with hybrid therapy. But what do current guidelines recommend between intermittent and continue? KDIGO guidelines, published 14 years ago, suggest using CRT unstable patients. But we don't know what is hemodynamically unstable patient. There is no definition for me. In France, we have French guidelines, and continue and intermittent may be used both equally in our ICU, but taking into account their availability and the experience of the team, of course. And I think in this editorial by Paul Palevsky, an international expert in this question, he stated very important things, stating that intermittent and continue provide equivalent outcome is misleading if it is not acknowledged that similar outcome may not be achievable with the short, rapid treatments that characterize most inpatients in hemodialysis in US and also in Australia. So we have to extend the duration of the session from 3-4 hours to probably 6 hours or more. What is the definition of hybrid therapy? It's a form of kidney replacement therapy that offers a diffusive or convective clearance and that is longer than a standard hemodialysis, but no longer than 24 hours a day, of course. So you could use this kind of modality with a hemodialysis machine or with CRT machine. The first description was published 24 years ago. It's a very small study with 25 patients receiving extended daily dialysis, which is hybrid therapy. And the comparison between a control group receiving continue show that there is no difference according to the hemodynamic. Another secondary outcome, patient treated with hybrid therapy required significantly less heparin in this study. And as you can see now, everybody can use hybrid therapy in the ICU. There are many machines. You can do hybrid therapy with many machines. You can use diffusion only, convection only, or diffusion and convection. What are the treatment parameters to use this kind of therapies? The blood flow should be set between 200 and 400 milliliter per minute. It's between intermittent and continue. Dialysis flow rate between 60 and 200 milliliter per minute. The typical UF rate is between 0 to 400 milliliter per minute. Of course, remember, we should use conservative ultrafiltration when we want to treat our patient with intermittent RRT. The duration could be 6 hours, 8 hours, 12 hours, and the frequency is between 4 to 7 sessions per week. So are hybrid therapies frequently used? No. In START-AKI trial, Rinaldo showed different results of START-AKI, including more than 2,900 patients. Only 4% of these patients receive hybrid therapies. The SLED was most often used in emerging countries in this prospective international study, 45% compared to 4%. So it's probably interesting to use this in a low-income country. And the potential indication for PIAT in this paper, it could be used as a substitute for CRT to treat hemodynamically unstable patients. It could be used as a substitute for intermittent hemodialysis or for the de-escalation of the treatment in the ICU. So, as you can see, I disagree with Rinaldo. I think that, of course, we should use continuous CRT for some patients, and specifically patients with acute brain injury. But for the others, okay, we have to use intermittent for patients with dialysable drugs, but for hemodynamic instability patient, I don't know exactly what it is, or patient with very large fluid overload, there is still a debate. There is still a debate, and probably there is a place for hybrid therapies. The advantage of these therapies compared to CRT is they facilitate the performance, the transportation, the rehabilitation, and other procedure. And you know that rehabilitation is very, very important for our patient in ICU because it is associated with improved mobility and with improved muscle strength and possibly improved day alive after the hospital. There is less need for anticoagulation. You can use also citrate anticoagulation in this modality. It is cost effective. You can see that it's less expensive than continuous renal replacement therapy with citrate or heparin. And it offers utilization of one RT machine for up to 3 patients per day. And it's not a detail. Remember, during the COVID-19 crisis, some intensivists in New York experienced shortage with RRT. So in this context, you should use intermittent hemodialysis. So what are the clinical studies comparing hybrid therapies and CRRT? There are few studies, but with methodological bias. These small retrospective studies include more than 1,000 patients. It was not a randomized control trial, but the author states that the change from continue RT to PIAT was not associated with any increased mortality after adjustment. This second study, it was a cohort study. Here again, it's not a randomized control trial, but the result is that comparing to continue, there is no difference according to the mortality after 30 days and no different according to RT dependency. It was the first randomized control trial, a small randomized control trial with 232 patients published 10 years ago. And as you can see, there is no difference in terms of mortality after 90 days after randomization. But the secondary outcomes are interesting. SLED had a significant fewer days of mechanical ventilation. SLED patients had fewer days in the ICU, and SLED patients need fewer blood transfusion in this study. And finally, probably it's the most important things, the nursing time spent during a RT session. So you can see that, of course, for intermittent or hybrid therapy, it's better than continue. And if you want to use this kind of therapies in your ICU, there are different models of nursing support, and we know that it's probably a big difference between France, United States, and Australia. Rinaldo Bellomo highlights this kind of ICU staff organization. You can have a ICU nursing model or dialysis nursing model, or probably the best, a collaborative model, including ICU and dialysis nurse model. So, to summarize this talk, hybrid therapy is a kind of intermittent renal replacement therapy done properly for our ICU patients, even with hemodynamic instability, with many advantages. Hemodynamically well tolerated, facilitates the transportation, the mobilization, no need for anticoagulation. It is cost effective, and you can use one machine for 3 patients a day. Few limits, no guidelines for the dose, for the frequency, for the medication during the therapy, and there is probably a risk of hypophosphatemia and hypokalemia, but like the other RT modality. And finally, I think that we can conclude that we need more high-quality studies on this question. Thank you very much for your attention.
Thank you very much. Are there any questions from the audience? Yes, please. Wait for the microphone, please.
I have a question. The hybrid therapy, you do it in the intermittent hemodialysis machine with the need for water station, or on the CRRT machine?
Both are. It's possible to use both. It's possible to use CRT machine and intermittent with water, no problem.
No.
And you know, now you can also. I show this result of the study. It's under review. But you can also use CRT machine to provide intermittent hemodialysis. It's possible. It's possible. It's a setting. And during the COVID-19 pandemic, some of our colleagues in Paris used this modality. You have just to put the 2 dialysate flow in the same line,
okay.
And you can obtain 9 liters per hours of dialysate flow. And it's possible to provide intermittent. During the COVID-19, it was possible. And it allows a good dose. You will see the result of the study.
And the filter that you used, that was for the CRT with 600K, yeah?
Sorry?
The filter that used in the circuit.
Yeah,
It was
yeah. It's the filter of the CRT machine. Yeah.
Thank you.
Yeah, exactly.
Well, thank you so much.
Thank you very
Sake
much.
of time will continue. Thank you for keeping us on time. All right. We continue the program with Dr. Tomoko Fujii.
Thank you very much for the introduction. I'm Tomoko Fujii from GK University Hospital in Tokyo, Japan, and this is incredibly honor for me to share my talk in this session. So my topic is optimal dosing. So disclosures to governmental and public research funding for a clinical trial I will present at the end of this presentation. So previously in 2000 or 2005, so many people discussed if increased dose of CRRT or IRT, intermittent IRT, benefits patients with acute kidney injury. And multi-center randomized clinical trials, they focused on the effects of renal replacement therapy dose on patient outcomes in acute kidney injury. But the studies did not demonstrate a beneficial effect of higher intensity renal replacement therapy on patient survival or renal recovery. And they provided valuable insights into the dosing of continuous renal replacement therapy and its impact on outcomes in critically ill patients with AKI. So these two are the landmark clinical trials. Both of them are published in New England Journal of Medicine. The first one was ATN trial. It compared intensive therapy, intensity strategy, which comprised of intermittent hemodialysis and SLED 6 times per week, or CVV-HDF 35 mL per kilo per hour, and low intensity therapy, which comprised of intermittent hemodialysis 3 times per week, or CVV-HDF 20 mL per kilo per hour, and they recruited 1,000 patients. And the second one was Renal trial, published in 2009 by the group of Rinaldo Bellomo, and they compared high-intensity CVV-HDF, which was 40 mL per kilo per hour, and low-intensity group, which was CVV-HDF with 25 mL per kilo per hour, and they recruited 1,500 patients. And neither of them demonstrated any benefits with the higher intensity CRRT or IRT. And the systematic review published in Cochrane in year 2016, they found 6 trials, compared high-intensity CRRT and low-intensity CRRT, and the benefits of high-intensity CRRT was not proven in the systematic review. And I would like to highlight that high group in the systematic review all received 35 or 40 or 45 mL per kilo per hour, which is obviously high intensity, and low group received 20 or 25 mL per kilo per hour. So this was, so to say, high versus low in year 2000 around so. So it seems the things are concluded. And KDIGO international guidelines stated that we recommend delivering on effluent volume of 20 to 25 mL per kilo per hour for CRRT in AKI. And this will usually require higher prescription of effluent volume. So this case closed. While in East Asia, where I came from, they are doing something different traditionally and due to the regulation. So the first report, I reported that we collected all the data from intensive care unit patients who received CRRT after admission from emergency department. After the adjustment for Apache 2 score, the ICU mortality rate was similar to what was observed in the clinical trials that was observed in the clinical trials who received, so to say, low or high intensity CRRT. And recently, my fellow published another observational study conducted in general ICU. Again, we adjusted for severity score, Apache 2 score, and still we observed ICU mortality as low as 13.4%. And both study found that patients received lower, very low intensity CRT. The first study reported at 16.7 mils per kilo per hour, and the recent study reported 14.2 mils per kilo per hour on average. So, lower CRT is provided to patients in the ICU in our country particularly. And when we think about this, what can explain this phenomenon? And another implication from trials and timing can teach something. So this START-AKI trial, which has been mentioned several times in this session, they compared accelerated strategy and standard strategy. And accelerated strategy was to start early, the CRT, and the standard strategy was to wait until absolutely necessary. And in this trial, accelerated strategy was not superior and possibly harmful for the renal recovery because in their secondary outcomes, RRT dependence among survivors at 90 days were reported, and there was a slight increase in accelerated strategy. So this finding may tell us something that exposure to renal replacement therapy may interfere kidney repair and its functional recovery. So there are more explanations behind this hypothesis, because we can think of several potential harms of excessive CRT or CKRT, because electrolytes and acid-base equilibrium may be modified too much, excessively. And as they observed in renal trial, higher intensity CRT was associated more occurrence of hypophosphatemia. And also excessive CRT can eliminate amino acids from blood, and also water-soluble vitamins and trace elements can be easily removed. And also, what is important is that it can also eliminate antibiotics or some key medications to treat patients. And other issues can include heat and circuit-related troubles and impacts on hemodynamic monitoring as reviewed. So these potential harms of excessive CKRT has been mentioned like an idea of dialy trauma in 2012. And here is an interesting experiment reported in NDT in 2013. This experiment used mice to compare kidney weight after shunt control and unilateral ischemia by cross-clamping renal pedicle, which mimics kidney injury without uremic milieu, and also bilateral ischemia to mimic kidney injury with uremic milieu. And interestingly, when both kidneys underwent ischemia, a kidney's size and mass were preserved, as you can find in the photo on the right side. But contrary to what happened with unilateral ischemia, where there was a significant reduction in kidney mass. So, proposed effects of uremic milieu on renal recovery after AKI. So, this is still a hypothesis, but probably sensing of uremic milieu may induce production of various growth factors and survival cell signalings, or paracrine effects may lower the inflammation and or oxidative stress, and or facilitating a cycle of repair and recovery. So this ideas is called so-called permissive azotemia among some researchers, and as reviewed in paper published in 2022. So this is the hypothesis. So high-intensity renal replacement therapy failed to improve patient outcomes, and accelerated initiation of renal replacement therapy did not improve patient outcomes, and possibly do some harm to our patients, and to avoid so-called dialytic trauma or permissive azotemia to allow. And then patients with severe acute kidney injury requiring renal replacement therapy may benefit from lower intensity of renal replacement therapy. So we're conducting a randomized clinical trial to test this hypothesis, and we've just started the patient recruitment. So here are some key takeaways from my talk. High-intensity CRT over 35 mL per kilo per hour was not proven to improve patient clinical outcome and potentially harmful. And medium-intensity CRT is recommended as a standard care. But clinical and experimental research implies exposure to renal replacement therapy may interfere kidney recovery, which is called dialytic trauma or permissive azotemia. So exploration to find the effective and safe something floor intensity of CRT is ongoing. Thank you very much.
Thank you very much for a very clear presentation. Any questions from the floor? Please use the microphone. Yes.
I have a question. Thank you for your interesting talk. What is the reason in your country that the delivery is so low, unexpectedly low, below 20 or 14.7?
It's mainly due to the regulation by the authorities. It imposed the maximum limit of dialysate fluids so that we can use during one day session. Yes, so that's the main reason, but it's traditionally conducted in this way. So we're trying to find out what should we do, whether we should change our practice and submit our data to government or not, and then we have to do clinical trials. So we're doing it.
It's interesting because probably you shouldn't change your practice.
Well, but yeah, but if there's a rationale to decrease the amount of fluid because some experimental data support the lower intensity of CRT. So we've been worrying whether we're under-dialyzing patients or under-treating patients, but it seems that things are not so straightforward, and so we're testing the hypothesis.
Okay. Very good. Any further questions?
Do you think that the dosing should be kind of a set it and forget it like we are right now, or should it be titratable? And if so, what should we base that off?
So you mean one size does not fit all for all patients?
So currently we use 25 mils per kilo or sometimes 30 mils per kilo, and then we set it and we keep going, and then we stop when we decide to stop, but we don't actually titrate it or wean our RT. So I'm just wondering what your thoughts are.
Yes, that will be another hypothesis because we may not need to provide this simple one strategy to the patients the whole journey in the ICU. So yes, that will be another hypothesis. Yes, that's reasonable, I suppose.
Thank you so much.
Thank you very much.
Now, next and last, I'm afraid, of this interesting afternoon is Peter Pickers from the Netherlands. He will talk about thermoregulation as a physiological variable during hemodialysis. Peter, the floor is yours.
Thank you very much, Mr. Chairman. I have to make a confession first. When you are asked to speak at this meeting, a couple of months ago this happened, you were asked to submit a couple of subjects to talk about. And at that time I thought that I would be ready with a study that we are conducting on thermoregulation in renal patients. And I must say, progressively in my life, things go less quick than I think. So I have very limited data on that, but I will still give you some background and why I think it's relevant, and I have a sample of a patient. So this talk is about thermoregulation. And I think it's very clear that medicine has been obsessed with temperature. From the very beginning of medicine, temperature was thought to be very relevant. Hippocrates likely, or maybe Parmenides, said, "Give me the power to produce fever and I will cure disease." And many years later, it was William Osler, who's also frequently quoted, a very smart physician, and he said, "Humanity has three great enemies, and by far the worst enemy is fever." So fever is a very important thing, and medicine has been obsessed with temperature. And of course, this is all focused on fever and infectious diseases, but what about hypothermia? Maybe could we also use that as a measure of volume status, that during hypovolemia that there might also be an effect? Well, we do have, this is even an old slide, I changed it I thought, but we do have some data in patients with heart failure. So the thing is that if you are admitted to the hospital with acute heart failure, you are treated and then released from the hospital, about 40% of these patients are readmitted within 3 months for heart failure again. So it's an enormous relapse. And the other problem is that the vital signs of these patients do not really predict who is going to be readmitted to the hospital. And so the thing is, we are measuring vital signs in the ICU all the time, but these are the consequences of buffered systems. So these are compensated and buffered, and they do not change easily. So what we are measuring now with a new device is not temperature itself, but the amount of heat that a patient is producing, how much heat he is radiating. And if you look at these graphs, and I will explain them in detail later, you can see that in the healthy upper graphs, the graph actually shows a day-night rhythm that looks like a boomerang. And in the heart failure patients, the variability is much less. It's more like a ball. So this is a difference between healthy and heart failure that we have data from so far, that the variability of producing heat varies much more if you're healthy. So in these graphs, every time it's on the x-axis, the actual temperature, and on the y-axis, it's the amount of heat you are producing. And it's less in heart failure patients. So the idea is that if you would actually send home people with a device like this, you would be much more sensitive in measuring deviations from normal and knowing who is actually not doing well and could be resubmitted. So the main change in thinking is that normally we are aiming for homeostasis. And that means that there's constant external stress and we want to remain the same. And so we have all these difficult chemical and biological systems that work together to maintain that homeostasis. But this is a largely buffered system. And so the same is the case for temperature. So there are ways that the temperature could fall or increase, and it's mostly related to sympathetic tone and perfusion, that you can regulate the amount of heat that you will radiate, and you have to maintain this temperature very narrowly within limits, because very small deviations from the core temperature dramatically alter the rates of all chemical reactions. All enzymes in your body are temperature dependent. And so how the body is able to regulate core temperature at 37 degrees Celsius is essential to, or actually maybe is, homeostasis. So the idea is that if we are able to measure this temperature homeostasis, and not only temperature itself, then we have a quantification of the buffer capacity of this homeostasis. So it's a measure of physiological reserve. And so apart from inflammation, where the focus is on fever, could this be a measure of volume status? Well, to shortly explain how this is done, the temperature is regulated by the hypothalamus. This is the complex way that it works. To put it more simply, the set point is on 37 degrees. It's dependent on the ambient temperature, and then there are mechanisms for heat generation and heat retention or loss. Now, there is a new device. It's like a Fitbit. You can wear it like a watch. And this device is able to determine the amount of heat that you produce, that you radiate. And it does so like every 20 seconds, and it sends a signal to the cloud, and then you get these graphs. So again, this is called a Scolander plot. On the x-axis, the actual temperature. On the y-axis, the amount of heat that you produce. So normally you are within this normal range, within this triangle. If you exercise, you will produce more heat, but you will have the same temperature. If you have a fever, you will actually produce also more heat, but you will also have a higher temperature. So why can we measure this at the wrist, and why is this a good surrogate for total body heat production? This is likely because we used to walk on our hands and feet together. And just realize that we can feel our pulse, the radial artery here, and that's just crazy that we have such a big artery that is just feeding the hand. So there's a huge shunt. It's going back directly. And the reason for that is that with these shunts that you have in your hand and your feet, you're able to radiate a lot of heat to the floor that is colder. So when you had to do activity that would actually increase your core temperature, and that's not what you want, by having shunts in your hand and your feet, you're able to radiate a lot of heat to the floor. And so the measurement of the heat production at the wrist is a very, very good predictor or measure of your total heat production because of this. I will skip this. So again, normally you are within this normal triangle. You can produce more heat, you can have a fever, and so you can have these like autographs or fingerprints of normal homeostasis. So this is an example of a normal subject, and there are different patterns when somebody is sleeping. So just to illustrate, the temperature is pretty similar, but you produce more heat or less heat to keep that temperature at the same amount, right? And if you exercise, then you produce much more heat just to keep your temperature at the same moment, right? So this is it. So to show this in a movie clip, and I love these movie clips, this is a normal subject. So this is 20 seconds per time, so this is 24 hours in total in 10 seconds now. And you can see more production, less production, to keep the temperature pretty stable. And it's going up and down, and then in the evening he goes to sleep. Then you cool off a bit, and then within the sleep you're going up and down to maintain that same temperature again. So this is normal for a volunteer that is sleeping and awake. So now we also give endotoxin to healthy volunteers in my institute. Endotoxin from E. coli, and then the volunteers get sick for a while, and they will have a fever, and they are chilling, like a sepsis model, right? So the cytokine levels are high. So we measured a couple of these volunteers as well. So this is before the endotoxin administration. Then they get the endotoxin. Actually, they go down, so they maintain heat, and then they go up, and they radiate heat, and they have a fever. So the idea is indeed, at the beginning, before they actually develop a fever, they go down. They are actually containing all their heat to increase their core temperature, and then they go up, and then they have a fever. The temperature is higher, but they also start to radiate much more heat. So we did this in only 5 volunteers, and this is the unique pattern. So with 5 volunteers, we had a p-value of 10 to the minus 6. Nobody that is not inflamed will have this unique pattern of going down and then going up. So this could be a very nice way that before you actually make a fever, you can actually see this autograph, and it might be useful in detecting early that an inflammation response is there. Now, this is the only data that I have in dialysis patients so far. So we thought, well, maybe indeed, if this is a measure of volume as well, apart from the whole inflammation story, it could also be helpful and we used actually the dialysis patient as a model in which all of a sudden the volume status is changed. There's no other human model for that. So this is before dialysis. And then during intermittent hemodialysis, what happens now. It goes down, you actually cool off a little bit as well, but you're actually try to maintain all the heat that you have. End of dialysis, you go back to normal. So what we did here in a dialysis patient was more a model of what we want, showing that volume status can also be determined by this device. So what we are now looking for is to see, can we actually use this as a measure how much fluid we want to get out of that patient, because there will be a signal that it's too much before. For example, we have septic shock patient, he's still on a bit of norepinephrine, he's overloaded with edema now, and we think we have to get rid of some fluids. We start doing that, and then normally we try to do that until we have to increase norepinephrine, because then the patient cannot handle it. We think with this, we might be able to be more sensitive, and that the body already is giving a signal that I'm containing so much heat now, this is too much, and you have to slow down with your fluid retraction. So this is my talk on this. Sorry that I have no more data at this moment. Hopefully next year I'll come back and tell you some more. This is a very simple device. We need technical validation, of course, but it's a very interesting new thing, I think, that we can actually measure what the hypothalamus is actually telling to the body and doing. So we hacked the hypothalamus with this device. We're not measuring the consequence, we are actually measuring what the body is aiming for, and that's very nice. Thank you very much.
Thank you very much. Even without data, it was very informative and very interesting. Are there any questions? If not, can you comment on the variability of the body temperature? Because we know that variability in biological signals tells us a lot. Think of heart rate variability.
Yeah.
And the hormone variability over the 24 hours. Is there any signal in the temperature signal too that may be correlated with disease or with upcoming disease?
Yes, excellent. And I think overall speaking is that during disease, variability decreases. Heart rate variability. So the body's thinking, we have no time for variability now, we have to focus, we're sick. And so this is also what we see in the heart failure patients, that they have much less variability than the normal variability in healthy people. We have to measure this in multiple patients, and we have just started, so I have not much data there. What we do have is some data in healthy people, and what is interesting also is that everybody has their own boomerang. They're not the same. So what is really easy for this device, and it's coupled to machine learning, etc., that there's a lot of data, and that the computer will actually learn what your or mine normal variability is. And then from that, a deviation from that can already give a signal something is wrong. This is much better than normal values of blood pressure or heart rate or whatever.
And it probably will show you the signal earlier than any other signal.
Correct.
May I? Sure. This is very, very, very cool data, Peter. A quick question. So you're focusing on fluids, but I wonder if these patterns that you're looking at in heat production and how the body handles this may be telling something about the endothelial health as a metric of what the body can or cannot do. I was very enthusiastic about you saying that this is a way to measure the reserve capacity of the body. And I wonder if, again, the fluid application seems excellent, but I wonder if there's a more mechanistic insight that you could derive from this in terms of how the endothelium is behaving, because it depends on whether or not you can constrict to save your energy, right?
Yeah.
Your heat.
Yeah, I think it's mainly orthosympathetic tone. And that sympathetic tone and vasoconstriction is the main driver to maintain heat. And that this actually is a measure of perfusion. And it's similar that we try that we actually say in a septic shock patient, the skin is mottled, or we look at capillary refill time, etc. It's all the same thing. It's perfusion. And it's the same thing that the body is trying to contain things because intravascular there is underfilling. So that's, I think, the main driver. I'm not sure. We actually also measured in the gynecology ward a patient with preeclampsia, and we found indeed that there is actually a huge heat production, contrary to what we anticipated. And then treatment is there, and she becomes normal. Then treatment fails, it goes to abnormal again, and then the delivery of the baby is there, and she turns normal. And all the vital signs are pretty much the same. So it's way more sensitive and earlier. And so the thing is now, we have this for a couple of months, and we are looking for indications. And so we just have to try out. And the focus of us is mainly on infectious diseases. So we are working with hematology, for example, for neutropenic fever would be of interest. Or fluid status, volume status. These are the two focus subjects now.
Yeah, very interesting. It's a new vital sign.
Yes.
Thank you very much. Well, if there are no more questions and comments, yes, please.
One question.